esophageal choreography certification program. Without further ado, I would like to invite Prof. Kanchi to take over the stage from here. Prof. Kanchi, over to you.
Thank you very much for your kind words. At the outset, I would like to thank the organizers of this meeting on perfusion optimization in cardiac surgery and the opportunity provided. I'll just share my screen.
Yep, your screen is good, Prof.
Yes. So this program is about perfusion optimization cardiac surgical population. And we are the two faculty members, Dato Suhaini bin Kadiman and myself, and we'll be with you for the next 1 hour or so. And please feel free to comment or post your questions on the chat box. The objective is to explain the differences in perioperative hemodynamic monitoring management and goals in cardiac surgery, and establish a dedicated group of clinicians interested in promoting education and incorporation of advanced hemodynamic principles in the clinical practice, and hemodynamic education for sustained clinical advancement. The learning methods here include video on demand, networking, and engage in live meetings. So far, we have done one meeting in the month of August that included fundamentals. And today we'll be going to the next step, that is the intermediate stage, where we are going to deal with the cerebral perfusion and management. And I'll be talking to you about the personalized hemodynamic management. That is, one size does not fit all. That is the topic I'm going to deal with. And the schedule is like this. We'll be having the sessions in November, December, January, and February. Please join us. And the schedule is mentioned here. And in addition, we'll be having the video on demand, which I request you to have a look at it before you join for the session. With these opening remarks, I would like to invite you and also request and invite Dr. Dato Suhaini Kadiman to be with us for the next 1 hour to be able to continue the pathway of learning, education, ultimately providing the benefit to the patients. My topic today is one size does not fit all. What are the personalized goals in hemodynamic management? Achieving hemodynamic stability with both macro and micro circulation during high-risk surgery and in critically ill patients can be a formidable challenge in the clinical scenarios. There are several parameters to go by, and there are several monitors, some invasive, some non-invasive, that may guide decisions to administer intravenous fluids, vasopressors, inotropes, and other treatment modalities. The crux of the problem is that we need to know what is the optimal mode of monitoring and what is the optimal treatment for a given particular patient. Before actually I start the talk, I would like to mention that today is 2nd of October, the birthday of the Father of Nation of India, and I would like to convey my best wishes to all of you. And today happens to be the 152nd birthday of this great man who was responsible for India's independence. Coming to the lecture proper, I'll be dealing with pathophysiology of oxygen delivery and consumption. What is the importance of perfusion pressure? How autoregulation plays an important role in maintaining the blood perfusion to the organs. What do you mean by goal-directed management? And I will also touch upon microcirculation versus macrocirculation and how we can protocolize or personalize the care of patients under our care. And ultimately, I will conclude with does one size fit all and what is the role of personalized medicine in the current practice of anesthesia and critical care, especially in high-risk patients. Coming to the targets for cardiovascular management, there are two principal targets which are mentioned here. We need to maintain the perfusion pressure, which ensures adequate blood flow to a particular organ, and we need to maintain oxygen delivery. So these two are the basic requirements for the health of any particular organ and the health of a particular individual. The perfusion pressure depends upon the difference between the mean arterial pressure and the outflow pressure, and the mean arterial pressure in turn depends upon the vascular resistance and the cardiac output, which in turn depends upon the heart rate and the stroke volume. The oxygen delivery depends upon the cardiac output and the amount of oxygen carried in the blood, that is the arterial oxygen content, which in turn depends upon the hemoglobin, percentage of oxygen saturation, and the partial pressure of oxygen in the arterial blood. Coming to the oxygen content, the oxygen content is the amount of oxygen bound to hemoglobin plus the amount which is dissolved, and normally the arterial oxygen content is of approximately 20 ml for every 100 cc of blood. Similarly, if you look at the oxygen content in the mixed venous blood, it is about 15 ml. So we get arteriovenous difference of about 5 ml for every 100 cc of blood. Oxygen delivery is the amount of blood which is delivered to the tissues every minute, and it's a product of the cardiac output, the oxygen content, and this equals to about 1000 ml every minute. The oxygen delivery, when it's expressed in terms of body surface area, it's about 500 ml per minute per meter square of body surface area. Then the arteriovenous oxygen content difference, we already said about it, is about 5 ml for every 100 cc of blood. And the oxygen consumption is the rate at which oxygen is removed from the blood for use by the tissues, and it's approximately 250 ml at resting conditions every minute in a given individual. The relationship between the oxygen delivery and consumption is expressed as oxygen extraction ratio, and it ranges from 0.25 to 0.3, which means that anywhere from 25 to 30% of the oxygen which is delivered is consumed by the tissues. Now coming to the pathological states, in this pictorial representation, we have the oxygen delivery on the horizontal axis and the oxygen consumption on the vertical axis. And as long as the delivery is maintained, there is aerobic metabolism. But at a critical point, when the oxygen delivery falls below this critical point, four things happen. That is, anaerobic metabolism starts, and the lactates begin to rise, and there is decrease in the mixed venous oxygen saturation, and the patient promptly enters the phase of shock. So this critical point is important for us to identify the first aspect of our target, that is the oxygen delivery to the tissues. Coming to the second aspect is the perfusion pressure. This perfusion pressure is usually the difference between the mean arterial pressure and the central venous pressure. In most organs, this is the perfusion pressure. What is the mean arterial pressure and what is the central venous pressure? This is the difference between the inflow pressure and the pressure exerted by the central venous system. But this, if you know, the perfusion pressure is different in different organs. What is good for one organ may not actually be reasonable for some other organ. This is especially true when you talk about the heart. In the heart, the left ventricle is perfused during diastole, and hence the diastolic blood pressure becomes more important. And the coronary perfusion pressure typically is the difference between the diastolic blood pressure and the left ventricular diastolic pressure. So this needs to be kept in mind. The second point I would like to mention is about the autoregulation. In this pictorial representation, the horizontal axis represents the perfusion pressure or the mean arterial pressure, and the vertical axis represents the blood flow. And if you look at the blue curve is the autoregulatory curve, and in the flow, in the flat portion of the curve, irrespective of the mean arterial pressure or the organ perfusion pressure, the blood flow is maintained, and this can be subdivided into vasodilatory zone and vasoconstrictive zone. So as the pressure increases, because of the intrinsic response of the vessel, there is vasoconstriction trying to maintain the blood flow at this zone, whereas in the zone which is down below in the same line, there is vasodilation occurring to maintain the blood flow. Beyond these autoregulatory limits, the blood blood flow to a given organ is passive, in the sense that if the blood flow is decreased in this part of the curve, and blood flow may be increased in this part of the curve. This is the classical representation of cerebral autoregulation, and we have the lower limit of autoregulation here and the upper limit of autoregulation here. As I said, these limits have been determined as 50 millimeters of mean arterial pressure and 150 millimeters of mean arterial pressure, respectively, in healthy individuals. This has been data derived from 11 human studies published somewhere in 80s and 90s. But the validity of this concept may be criticized, because we know that the cerebral blood flow is determined by more factors other than blood pressure alone. There are a variety of physiological and biochemical parameters which may interact and cause a change in the autoregulatory limits in a given particular patient. This is especially so if the patient is having a disease state such as long-standing diabetes, long-standing hypertension, and patients who receive vasodilators, for example, sodium nitroprusside or nitroglycerin, or even anesthetic like isoflurane, may alter the characteristics of the cerebral autoregulation in a given clinical situation. This has been amply demonstrated in this study, where with the use of sevoflurane, sodium nitroprusside, the nitroglycerin, sodium nitroprusside, the relationship between the mean arterial pressure and the cerebral blood flow has been different in different circumstances, where there is pharmacological manipulation of the circulation. The autoregulation may be different in different situations. For example, this autoregulatory curve may varies from the typical classical depiction of the autoregulation, where the autoregulation much reduced, and in a given patient with pathological conditions or with vasodilations vasodilatory drugs being administered, the shape of the curve will be difficult to determine. And here the cerebral oximetry may play an important role to determine the autoregulatory limits in a given particular patients. If you have a composite of the mean arterial pressure and the oxygen saturation, in this case, we are talking about cerebral oxygen saturation, we may derive what is called as the cerebral oximetry index, which is normally 0. If the cerebral oximetry index is 0, the autoregulatory mechanisms are in operation. But if it goes away from 0, for example, it becomes 1 or -1, the autoregulation is impaired. If you take, for example, if you take two different patients, we have the cerebral autoregulation indirectly measured through the regional oxygen saturation using cerebral oximetry. We have the cerebral oximetry on the vertical axis and the mean arterial pressure on the horizontal axis. There are two different patients, and they behave differently in terms of cerebral oxygen saturation and outcomes. For example, we will take the case in the upper panel. This is a patient who underwent coronary artery bypass grafting, did not have any risk factors. As the mean arterial pressure decreased less than 70 millimeters, the cerebral oximetry was continued to be maintained for a reasonable length of time, which means that in this patient, the autoregulation has been extended as low as 40 millimeters of mean pressure. So this autoregulation was maintained between 40 to 110 millimeters of mercury, as is depicted here. This is in strict contrast with another patient who had carotid disease and hypertensive, and as soon as the mean arterial pressure decreased to less than 70, the regional oxygen saturation decreased. This patient's clinical course says that the postoperative ventilator support was longer and ICU stay was longer as compared to this patient because of the possible decrease in cerebral blood flow when the blood pressure decreased to less than 70 millimeters. This is about autoregulation, and we'll just look into the fact of goal-directed therapy, which is the third component of my dealing with this subject of one size does not fit all. The first pulmonary artery catheterization report was done in 1970, and these authors, especially Swan Gans, the two authors, they published that they could pass the PA catheter in about 35 seconds in the first 100 cases. This was followed by Shoemaker's proposal that supranormal oxygen transport is beneficial for the patients who undergo high-risk general surgery, but these findings were not reproducible, and hence the supranormal oxygen delivery system proposed by Shoemaker et al. Is no longer validated in the current era. Then came reverse publication. The patients were randomly assigned to two groups. The first group received early goal-directed therapy, and the second group did not receive the early goal-directed therapy. They received the standard therapy, and the CVP was maintained between 8 to 12 millimeters of mercury in the goal-directed therapy, and the mean arterial pressure was 65 and above, and the central venous oxygen saturation was maintained above 70%. Using this early goal-directed therapy, Rivers et al. Concluded that this improved the outcome. There was a mortality benefit when the early goal-directed therapy was instituted. But in 2014, around that time, there were three other publications. For example, you take the process investigators from the United States and the ARISE investigators from the Australia and New Zealand, and we have the PROMISE investigators from the UK. All these authors said that strict early goal-directed therapy did not really change the outcome as long as you have given a standard care, which means that the standard care was good enough in these patients, who suffered sepsis. So these are the hemodynamic variables assessed at different points of time in the operating rooms and the ICUs. The question is whether we should take the population-based normal values or the patient's blood pressure in the ward before the surgery was being done, or you should take up the pre-induction values or the post-induction values and guide the therapy. So for this, the different concepts of hemodynamic therapy has been proposed. The first one is the early goal-directed therapy, where the patient's management is subject to protocolized care. And then you have the individualized hemodynamic therapy, where the blood flow can be maximized to suit the particular individual. And you have the personalized hemodynamic management, where there is optimization of blood flow and the blood flow is made adequate for a given particular situation. The 5 T's of perioperative goal-directed hemodynamic therapy include the selection of high-risk patients who are the target population, and timing of intervention should be early rather than late. And the type of intervention must be identified, whether it is, usually it is a combination of intravenous fluids, vasopressors, and inotropes to be able to achieve a target. And the target variable is the heart rate, mean arterial pressure, central venous pressure, pulmonary arterial occlusion pressure, stroke volume variation, pulse pressure variation, stroke volume, cardiac index, and what is the target value of these parameters must be suitably identified and delineated. And coming to the actual personalized case, this trial showed that the use of the compared streptokinase and TPA in two groups of individuals. For example, if you have an individual who is 72-year-old as compared to 52-year, the mortality risk in this individual is much, much less as compared to this when you're using the TPA in a patient who has suffered acute non-STEMI, acute ST segment elevation myocardial infarction. Now coming to the recent guidelines about the treatment of heart failure in patients who have heart failure with reduced ejection fraction in stage T, the ACE inhibitors and the angiotensin receptor blockers, along with beta blockers, are the primary treatment modalities, but the treatment then changes or modified depending upon the personal characteristics of the patient, especially if you look at this, the guidelines, if the patient is African American, you have to add hydralazine or nitrates, and this underlines the fact that these guidelines must be personalized to a particular patient depending upon the ethnicity in this example. If you look at the multicentric randomized parallel group clinical trial conducted in French University, 298 adult patients undergoing high-risk surgery were enrolled. Here it is clearly demonstrated that individualized management strategy aimed to achieving systolic blood pressure within 10% of the reference value, that is the patient's resting blood pressure, resulted in much better outcomes. What we have done in our own write-up, which was published in the Journal of Cardiovascular Anesthesia in the year 2019, we said that in Indian subcontinent, cardiovascular disease is rampant, and it is the commonest cause of death in adults in this subcontinent. And hence we have recommended that for patients undergoing non-cardiac surgery, the following investigations must be included in the approach to non-cardiac surgery in a cardiac patient. For example, we suggested that ECG, chest X-ray, echocardiography must be included at these points. The ones which are marked in a bit of yellowish color were suggestions from the original 2014 algorithm elucidated by the American Heart Association, American College of Cardiology, 7-step approach to patients undergoing non-cardiac surgery in cardiac patients. This is what we have done. We said that the cardiovascular disease is rampant in this subcontinent, and hence we would like to have little more investigations to look into the patient's disease status before subjecting the patient to elective non-cardiac surgery. Let's take this example. There are about 500 people in this crowd attending a talk, and the average age of individuals is about 41 years. And if you take the individual age groups, excepting 1 or 2 individuals, all the others were not 41 years. They were either less than 41 years or more than 42 years. And hence, we would like to underline the fact that one size does not fit all. There were several people who had different sizes, and we cannot individualize. We cannot say that one person is same as the other person. And if you look at the randomized control trials, to determine the treatment effectiveness, large-scale human trials have been done, which have led us to understanding the disease pattern. But the thing is, these trials give us the mean value of a particular parameter in a particular subset in a particular trial. But these mean values do not tell us what is the individual values. And when you're dealing with individual patients, how these mean values will be able to help us is a big question which we need to address. If you look at the village, a British village where the artist took the pictures of about 2,000 people and made the morphed them, put them in together and get the average value, average picture. The central picture here represents the average of that particular village, which has no resemblance to any of the individuals in this picture, which means that averages hide the individual differences. And in a large clinical trial, each individual may have different health histories and risk factors which may influence the outcome, and this may be hidden because we are going by the outcome, which again depends upon the mean results of any given score. The same thing, if you look at the Indian population, Indian subcontinent, we are 3 times vulnerable to cardiac disease, especially coronary artery disease. And if you go by the parameters and the values given by the Western world, are we doing justice to our patients? That's a question mark which we would like to take up and then answer the questions. And this slide delineates the differences of the protocolized and personalized hemodynamic management, and what are the advantages of protocolized versus personalized management, and can we put them together to get a better understanding of the hemodynamic goals and management. For example, if you take the protocolized management goals, they are rigid, the target values are fixed, and this is dependent upon normal values of that particular population. And the bottom line is that one size fits all concept here. But it is not so when you take the personalized hemodynamic management, because there is lack of standard. The problems with this management is there is lack of standardization, there is variability in care, and the algorithms becomes much more complex, and it is difficult to implement in clinical practice. Hence, we should have a strategy to combine both of them, resulting in functional hemodynamic monitoring, have adaptive target values, and have personal values as targets. What is the answer for this? Is the hypotension prediction index, which has been proposed by the Edwards group, is this the answer? We do not know. We need to look into the future to give us the answers. And to conclude, I would like to say that one size does not fit all. Protocolized, personalized hemodynamic management for precision in hemodynamic monitoring may be recommended, and artificial intelligence and big data may help us in personalizing the treatment strategies and improve outcomes. And this may become an essential part of personalized hemodynamic medicine. If you ask me, does one size fits all? I think it applies amply to a saree which is worn in Indian subcontinent. But even here, there are individual differences. Each saree is differently worn, and even here, there are individual differences. With this, I would like to conclude my talk, and thank you very much for this opportunity. And if there are any questions, I would like to answer them, but the question answer session will come later after the end of the second talk. And now I would like to invite Dato Suhaini Kadiman for his talk regarding cerebral perfusion and maintenance of cerebral physiology during cardiac surgical procedures. Thank you very much once again.
Thank you very much, Professor Kanchi. Good afternoon, Assalamualaikum, and a happy Gandhi Day for my fellow colleagues from India who are celebrating Gandhi Day. So, no one size fits all. I guess that is the conclusion from Professor Kanchi's talk. And that brings us to my presentation, how we want to interpret that concept into our practice of running our daily cardiopulmonary bypass. How does the cerebral blood flow in relation to our run of cardiopulmonary bypass, and how we can individualize or personalize the running of cardiopulmonary bypass in managing our day-to-day patients. So hold on to your coffee and let me bring you to understand this concept. Brain injury remains one of the most high-risk complication that we keep on encounter despite the advancements in the technology of heart surgery. And the brain injury can present to us in spectrum of severity. In the most severe form, patient will presented with a sudden death. In a mild form, they can present it to us with neurocognitive impairment, and in between, we can be presented with delirium, hemiparesis, or global stroke. And there are various factors that affecting brain injury after cardiac surgery. There are patient's risk factors, surgical risk factors, pharmacology, and what we would like to learn today is how the running of cardiopulmonary bypass poses a certain risk to brain injury. Our practice of running cardiopulmonary bypass has been rather constant for the past probably 65 years. So what we practice alpha stat, and we assume that the cerebral blood flow autoregulation is functional. We set targeted empirical perfusion pressure. Sometimes we do adjust according to age, preoperative blood pressure, or comorbid condition. But most of the time, we practice running the perfusion pressure of anywhere between 50 to 60. But the question is running the perfusion pressure of 50 to 60 really adequate? This is very much depending on very old data. It was based on younger patients with less comorbidity than our current patients. In my hospital, the spectrum of patients that we bringing in for cardiac surgery nowadays is extremely high risk and at the extreme advance of age. And therefore, certainly, we need to look into the concept of personalization to make sure that the outcome of surgery is very much better than what it used to be. So the question is considering a preoperative blood pressure useful for us to decide the perfusion pressure when we're running the cardiopulmonary bypass? This brings me to the study presented by Gottesman in 2006. What he did, he investigated the association between the intra-op blood pressure and the incidence of watershed stroke. This was done between 1998 to 2003 in Johns Hopkins, where he investigated 98 patients that developed clinical stroke. So when he looked back, he found that the stroke even happened even when the intra-op blood pressure was only merely less 10 millimeter mercury lower than the individual preoperative blood pressure. So certainly the preoperative blood pressure is not going to be useful for us to determine the adequate perfusion pressure when we run cardiopulmonary bypass during our cardiac surgery. So how to explain that? The only explanation is looking back into the cerebral blood flow autoregulation. So we assume that the cerebral blood flow autoregulation is intact between a range of mean arterial pressure. Unfortunately, the lower limit of autoregulation and the upper limit of autoregulation is very much individualized. It ranges, and we should learn how to determine the lower limit of autoregulation and the upper limit of autoregulation into our clinical practice to prevent complication of cardiac surgery. The other factors that we have to consider is mean arterial pressure does not equal to cerebral perfusion pressure. And therefore, we need a good monitor for us to understand the cerebral blood flow. So, what is a good perfusion pressure? To answer this, Joshi in 2010 has looked into 127 adults underwent cardiac surgery, and to understand and investigate the cerebral blood flow, he uses the transcranial Doppler, and he looks this in response to the change in the mean arterial pressure. He introduced a concept of mean velocity index. When the mean velocity index is 0, the autoregulation is intact. But as the mean velocity index approaches 1, the autoregulation is impaired. From his observation, he found out that 34% of his patients had a mean velocity index of more than 0.4 during cooling while on cardiopulmonary bypass, whereas 53% of his patients had a mean velocity index of more than 0.4 during rewarming, and 5% of his patients developed a stroke. And all his patients that developed a stroke had a mean velocity index of more than 0.4 during rewarming. Therefore, cooling and rewarming in cardiopulmonary bypass is associated with an impairment of the cerebral autoregulation. It is worse during rewarming. So the best perfusion pressure is defined as dose pressure with an intact cerebral blood flow autoregulation. So how to decide the best optimal pressure? This is again, this concept again has been looked by Daijiro Hori in 2017. He uses the same concept, use the transcranial Doppler to verify the cerebral blood flow velocity in response to the change in the mean arterial pressure, uses the mean velocity index. In his series of 614 patients, he managed to define the lower limit of autoregulation and the upper limit of autoregulation. The lower limit of autoregulation was found to be in average of 65 millimeter mercury plus minus 12, and the upper limit of autoregulation was found to be in average of 84 millimeter mercury plus minus 11. And he decided that the optimal perfusion pressure should be at 78 millimeter mercury plus minus 11. However, he also found out that 17% of his patients had the lower limit of autoregulation above the optimal mean arterial pressure. Okay, and 29% of his patients had the upper limit of autoregulation below the optimal limit of mean arterial pressure. Therefore, if we were to run our perfusion pressure at 78 as what being recommended by Daijiro Hori, we risk 50% of our patients to be either below the limit of lower limit of autoregulation or above the upper limit of autoregulation. And therefore, he concluded that the real-time monitoring of cerebral autoregulation may improve, individualizing mean arterial pressure during cardiopulmonary bypass, and then improving patients' outcome. We can measure the cerebral blood flow using either direct measurement or indirect measurement. The direct measurement might not be applicable in the operating theater, but the indirect measurement, we can use either transcranial Doppler. We could also monitor the jugular vein oxygen saturation, or we could use the near infrared spectroscopy for our extrapolation. So transcranial Doppler is a device that we can use in our operating theater. However, it has several limitations. It is a bit cumbersome to be applied, very much operator dependent, and 10% of the time we cannot access the flow via the temporal window, and therefore there will be an absence of signal. Okay, and I myself in my practice has not used the transcranial Doppler, but the one that is more practical for us to consider is the near infrared spectroscopy. There are various types in the market nowadays. They are all based on the Beer-Lambert's law. Their cerebral oximetry reading is very much reflective of the cerebral venous oxygen saturation because of the positioning of the probes at the frontal lobe. And therefore, it represents the area of about 5 millimeter cubic area in the frontal lobe of the brain. Unfortunately, all these various types of cerebral oximetry uses a different algorithm, and therefore comparison between them is rather problematic. But what we can do if we can familiarize ourselves with one of those cerebral oximetry in the market and come up with our own clinical experience and guidelines so that we can understand whether the cerebral oximetry that we choose impact the clinical outcome or not. So how does the near infrared spectroscopy perform in compared to the transcranial Doppler? Brady in 2010 compared transcranial Doppler with the near infrared spectroscopy. They used the mean velocity index for the transcranial Doppler and cerebral oximetry index for the near infrared spectroscopy. And he found that there was a good correlation between the mean velocity index and cerebral oximetry index. Not only that, he also found that the cerebral autoregulation was impaired during cardiopulmonary bypass, and the average were found to be anyway about around 0.38. And he also found that the lower limit of the autoregulation was found to be anywhere between 45 millimeter mercury to 80 millimeter mercury in his series. So noted the range of the lower limit of autoregulation. If you were failing to understand that each patient is different individually, so we would risk of running a complication in about, again, 50% of our population. And this is further supported by the study that is done by Joshi in 2012. He looked at a bigger set of patients, 232, again, comparing the transcranial Doppler and the near infrared spectroscopy. He found that there is a good correlation between the mean velocity index and the cerebral oximetry index. So he concluded that an autoregulation index measured with near infrared spectroscopy was able to identify impaired autoregulation. Again, Masahiro Ono compared the cerebral oximetry and the mean velocity index. So he looked into 70 patients underwent cardiopulmonary bypass, and he found out that there was a good correlation between the mean velocity index and the cerebral oximetry index. And the average mean at the lower limit of autoregulation was found to be at 66 millimeter mercury plus minus 11. So we now know that the near infrared spectroscopy is as good as the transcranial Doppler in determining the cerebral blood flow, and we are able to determine the lower limit of autoregulation by understanding the cerebral oximetry index. How does this translate into the clinical outcome? Masahiro Ono in 2013 looked into the outcome of acute kidney injury. 410 patients underwent cardiac surgery with cardiopulmonary bypass. So she found out that 121 patients, or 34.8%, had acute kidney injury within 7 days. And she found out that significantly higher duration and degree to which the mean arterial pressure is below the lower limit of autoregulation were the factor. Therefore, when we set the perfusion pressure below the lower limit of autoregulation, not only that we risk our patient for brain injury, the other organ also affected. In this case, we expose our patient to acute kidney injury. What about other major morbidity and operative mortality? Similarly, 83 of 450 patients were found to have a significant major morbidity and operative mortality when the area under the curve of the product of duration and magnitude of blood pressure were found to be lower than the lower limit of autoregulation. And therefore, the lower limit of autoregulation was independently associated with major morbidity and operative mortality after cardiac surgery. There is an extensive review done by Juliana Caldas in 2018. She looked into more than 2,500 publications related to cerebral autoregulation. And out of this, he selected 20 studies. What are the conclusions from her systematic review? Number one, there is a general agreement that cardiac surgery is associated with changes in cerebral autoregulation. So the cerebral autoregulation impaired in all cardiac surgery when we run patient on cardiopulmonary bypass. Number two, cerebral autoregulation recovered after cardiopulmonary bypass. It comes back to normal after we separate patient from cardiopulmonary bypass. Number three, the impairment of cerebral autoregulation renders the brain less tolerant to both low and high mean arterial pressure, resulting in either brain oligemia or hyperemia. This is important. Doesn't mean that high is always good to our patient. If we put above the upper limit of autoregulation, our patient will then develop edema or hyperemia in the brain. If we put the pressure to be lower than the lower limit of autoregulation, we subject them to oligemia or hypoperfusion. So the most commonly encountered neurological deficit after cardiac surgery was stroke, delirium, and cognitive decline. And therefore, duration and magnitude of the mean arterial pressure below the lower limit of autoregulation is again an independent risk factor for major morbidity and mortality. Two studies reported a significant risk of perioperative stroke with impaired cerebral autoregulation. And two studies stated 4 times higher incidence of delirium if we run our perfusion pressure above the upper limit of autoregulation. So higher is not good, lower also is not good. So we have to then be very specific and personalize the treatment for our patient. This is just a tracing that is common in our cardiac surgical operating theater in IJN. When we put our patient on cerebral oximetry monitoring, we trace them and we mark them and we match them with the perfusion pressure as well as the hemoglobin and the ABG results. And therefore we can explain, understand, and perform the necessary intervention to prevent complication from inadequate perfusion. So cerebral oximetry is very useful as an end organ monitoring for us to determine the cerebral autoregulation, not only to protect the brain from complication, but also other major organ from developing complication of either under or over perfusion. In summary, ladies and gentlemen, there are evidences to point that to use empirical mean arterial pressure of 50 to 60 as our perfusion pressure during running of cardiopulmonary bypass might harm the brain from inadequate cerebral perfusion and impaired cerebral autoregulation. There are evidences to show that by understanding cerebral blood flow autoregulation during cardiopulmonary bypass and manage the mean arterial pressure according to the cerebral blood flow individually, will then produce better outcome. Either we can use a mean velocity index or cerebral oximetry index. It depends to our resources and capability. The practice of cardiopulmonary bypass should incorporate monitors of adequacy of cerebral perfusion. Okay. However, the clinical outcome of the running of the cardiopulmonary bypass is not the solely dependent on the autoregulation oriented management. It requires consideration of other factors affecting the outcome of brain injury as well. With this, thank you very much, and I shall then open for questions from the audience.
Thank you, Dato, for that wonderful presentation on cerebral blood flow and the alterations caused by cardiopulmonary bypass. Thank you very much for that excellent talk. And to begin the discussion, I'll just open the question answers. There is one question about PB2O2 and NIRS. What is your experience on both? Would you like to take that question, or shall I make some comments on that?
Maybe you first, Professor Kanchi.
Thank you for that. The PB2O2 means the partial brain tissue oxygen tension. So the parameters measured by the NIRS is the saturation, whereas this PB2O2 is the oxygen tension in the brain tissue. This is the fundamental difference. And the normal partial pressure of oxygen in the brain tissue is about 23 millimeters with plus or minus 7 millimeters. And during neurosurgical interventions and patients who are neurocritical care, monitoring of brain oxygen tension may be indicated, and if the value of the oxygen tension in the brain tissue is less than 20 millimeters, it may be associated with worse outcomes. So here this may be a monitor to indicate the oxygenation, oxygen availability in the regional tissues of the brain. And actually, if you compare it with the near-infrared spectroscopy, the near-infrared spectroscopy is non-invasive. And in cardiac surgery, the most important indication, as far as I can say, is the use of cerebral oximetry or the NIS technology in patients who undergo antegrade cerebral perfusion in aortic arch surgery. That is to my mind, that comes first, because we need to know whether the cerebral, this circle of Willis is competent or not. So if the circle of Willis is not competent, when we're doing the antegrade cerebral perfusion by cannulating the right axillary artery or the right innominate artery, if the circle of Willis is not patent, the left side of the brain will not get perfused, and hence there is a strong risk of left-sided stroke in that particular patient. So the cerebral oximetry is of utmost importance to be able to tell us that the left-sided brain is not getting perfused in such patients who do not have a competent circle of Willis. So in which case, we can prompt the surgeon to insert a cannula in the left common carotid artery and perfuse the left side of the brain. So that is my comment on that question. If there are any, if Dato wants to, Dato, if you want to add, please feel free.
Yeah, thank you very much, Professor Kanchi. Any monitoring devices has its own limitation that we have to understand. As a clinician, we need to look into the limitation of each monitoring devices that we use.
Yes.
And from there, when we extrapolate, when we want to make an important clinical decision making, we should take that into consideration. For example, the cerebral oximetry. It is a sensor that is being placed at the forehead of our patients. It only measures 5 millimeter cubic tissues. So that represents most of the venous oxygen saturation at the frontal part of the brain. So whether we can generalize that or not, in most of the cases, yes. But there is also definitely an exception, okay? Especially when we want to look into occipital and parietal area. It's going to be difficult, especially if there is any issues with the circle of Willis and etc. But as far as the non-invasive monitoring is concerned, by implementing these monitoring devices, we has overcome the practice of generalizing our treatment to all our patients. The technology is advancing, and we should catch up with the technology. And at this particular moment, we should ride on this technology to save another 50% of our population from developing complication of brain injury or even other major organ injury by standardizing our perfusion pressure. So the practice should change. It doesn't mean that if we implement this, we will prevent totally, we will get zero incidence of stroke. No, we cannot, because we have to understand that the risk of stroke, there are 4 risks. Okay, there are patient risk, there are also surgical risk, there are also pharmacological risk, and there is also a cardiopulmonary bypass risk. So this is just a component of the cardiopulmonary bypass risk that we are trying to intervene. If there is a significant embolization, for example, in the case of thoracic aneurysm, there's a lot of debris, huge debris, and when we perform the operation and the debris embolize to the brain, I mean, no cerebral oximetry will help us from preventing the stroke, because the pathophysiology is different. In this case, we're trying to implement a cerebral oximetry to manage the cerebral autoregulation and to prevent 50% of our population from developing unnecessary brain complication from our standard of practice. Hopefully, this could answer the questions. Thank you.
Thank you, Dato, for that response. The second question is about experience in thoracic aneurysm surgery. How much percentage strokes is encountered is the question.
You first, Professor Chen.
Percentage of strokes encountered, and what is the experience? Shall I begin the reply?
Please, Professor Kanchi.
Yeah, a very interesting question. Thank you for that. We routinely use cerebral oximetry in patients undergoing aortic aneurysm surgery, especially when you are doing antegrade cerebral perfusion. As I said in the initial part of the discussion, it is an important component of monitoring these patients to be able to identify incompetency of these circle of Willis. Very important factor in these surgeries. If you look at the incidence of neurological insult, you can categorize them into type 1 and type 2. Type 1 is where there is a definite neurological deficit. The incidence is about 1 to 2% in the routine cardiac surgery. And if you look at the type 2 cerebral insult, it is neurocognitive or behavioral changes. This incidence can be anywhere from 30 to 50%. And in thoracic surgery as such, as the question directs to thoracic surgery, the incidence of neurological insult or neurological event is up to 10%, because we are directly dealing with the vessels which are supplying the brain, and the other associated factors like age, presence of atherosclerosis, peripheral vascular disease, anatomy of blood vessels, and other factors also contribute to the development of stroke in patients who undergo thoracic surgery. And the main important factor is the technique of cerebral perfusion and how we are going to monitor and address the issues then and there on the site in the operating room matters a lot. That would be my response.
Yeah, thank you, Professor Kanchi. Thoracic aneurysm and risk of stroke.
Yes.
In my institution, the risk of stroke is less than 1%. Okay. However, if there is a thrombus in the aneurysm, then the risk is different. So it depends. Again, we should look into patient risk, we should look into the surgical risk, and we should look into other pharmacological risk as well, on top of the cardiopulmonary bypass risk. All these 4 factors need to be considered and maintained adequately for us to reduce the risk of stroke. So in general, the risk of stroke is very low. After we have introduced the practice of cerebral oximetry, it evens further down. But
Yes.
there are incidences, especially if the patient's risk is not good, comorbidity, uncontrolled diabetes, there is a lot of atherosclerotic formation in the carotids, etc. There is a dissection associated with the thoracic aneurysm. There is a lot of debris, formation of thrombus. Definitely the risk will be higher. So when we calculate the risk and want to tell our patient, again, we have to then individualize this. It's good to quote the institutional rate of stroke, but
Yes.
sometimes we need to individualize. If your patient is a type 2 dissection with, aneurysmal descending thoracic, and there is a lot of debris all the way from the arch all the way down, and there could be a possibility that the surgeons might not be able to secure that. Okay, so then the risk will be higher. The practice of the integrate cerebral perfusion is also important to prevent the risk of stroke. So a long circ arrest is not going to be the standard practice anymore. As far as we can, we should then provide the integrate cerebral perfusion as we can. While waiting for the ACP to be established, we would like to build the oxygen reserve in the brain. This is again another concept that we can utilize our cerebral oximetry. Before you go on the circ arrest, you should build the oxygen reserve in the brain to allow the brain to withstand a longer time of a circulatory arrest before we can establish the ACP. Once the ACP is established, we then use the cerebral oximetry again to make sure that the perfusion that we deliver is adequate to maintain the saturation of the brain tissue. So these are the a few things that I can touch on in regards to the thoracic aneurysm surgery.
Thank you for that response, Dato. And the next question is, I think we have about 5 minutes to go. The next question is, do you have any protocol for patients who have low EF with regard to cerebral oximetry? Do you have any protocol for patients with low EF with regard to cerebral oximetry? That is the question.
Yeah, you first, Professor Kanchi.
Actually, the general protocol indicates that the cannula position has to be adjusted if there is any desaturation, cerebral desaturation of more than 20% from the basal or more than 50% of the absolute value. And then the carbon dioxide tension has to be adjusted so that there is no cerebral vasoconstriction because of hypocapnia. And the mean arterial pressure has to be maintained adequate to the needs of the patient's requirements. And hemoglobin and cardiac output have to be made. These are the general guidelines in the protocol-based approach to cerebral desaturation during cardiac surgery. Same thing will apply for patients who have low ejection fraction. Now, Dato.
Yeah, I guess Professor Kanchi did show in his earlier slide that our previous mode of modality of treatment is protocolized. So we are moving away from protocol. We are individualized nowadays.
Yes, yes.
So how does the cerebral oximetry plays a role? Cerebral oximetry will then decide whether a certain mean arterial pressure of certain cardiac output is adequate or not adequate for that particular individual patient. EF of 35 might be adequate for an individual. It might be not adequate for another individual. So what determines that?
Yes.
That will be determined by the end organ monitoring. And what are the end organ monitoring that we have? The end organ monitoring that we have, we can either look into urine output. We can look into the mixed venous oxygen saturation, or we can look into cerebral oximetry as the end organ monitor. So the studies have shown that if we maintain adequate cerebral oxygen saturation, we would then save our patient not only from the brain injury but also other major organ injury. So this is how we tailor the management of our patient individually by having the end organ monitor. So again, I would like to emphasize what Professor Kanchi has stated in his presentation. There's no one size that fits all. Protocol is good as a general guidance for us, but as we mature into managing our patients, we should be able to use the armamentarium that we have in our operating theater to individualize and personalize our management. Thank you.
Thank you. Thank you for that excellent comment. I totally agree with you. The cerebral oximetry is absolutely useful in looking at the autoregulatory limits in a particular case. And this may be useful in patients with low EF as well. Thank you so much. And a very quick reply to this question, Dato, please. What is the pharmacological risks for brain injury? That's what one attendee has asked. Can you quickly reply to that? Because I'm told that we are running out of time. What is the pharmacological risk for brain injury?
Yeah. Like I mentioned, the brain injury is a spectrum of presentation. It can present as sudden death, global stroke, or it can also present in the minor way in the form of cognitive dysfunction or delirium. Yes. So there are a few drugs that can cause cognitive dysfunction and delirium. You can read, there are a lot of articles that is being published that associated those pharmacological or medication towards developing cognitive dysfunction and delirium. One of those common drugs that we use in our operating theater is actually benzodiazepine. So we try to avoid we try ourselves best not to use benzodiazepine as the main drugs to prevent unnecessary cognitive dysfunction or delirium. And there are also other medication or drugs that is known to prevent cognitive dysfunction and even delirium. So blood pressure is not the only factors that can cause the brain injury. There are also other various factors that can cause brain injury. Thank you.
Thank you, Dato, for that response. I would like to thank you for joining me in conducting this session, and I would like to thank the audience for their participation, and I would like to hand over the podium to the organizing team. Thank you very much once again for joining us.
Thank you very much, Professor Dr. Kanchi and Dr. Suhaini, for your excellent sharing and a very practical approach in terms of, I think our take-home message today would be protocolized and personalized target. How do we keep that? Sari wearing in a different style. Okay, that's the message that we get. Yes. And we know that it is also important to hit the sweet spots of MAP to meet the cerebral oximetry index of equal to 0, so that we maintain the patients in terms of autoregulatory in the sweet spot. Okay, ladies and gentlemen, may I thank you very much for your participation in these sessions. I hope you enjoy the program as I do. Would appreciate if you could spare about 4 or 5 minutes of your time. Scan on the QR code, or we will send you a link for your feedback. Do tell us what you like and what are areas for improvement of these sessions. And also a gentle reminder to all that we have our third webinar will be coming on the 6th of November. So we are looking forward to meet you again in November. Okay, Bye-bye. Thank you. Thank you, Dato, and thank you, Prof. Kanchi.
Thank you. Bye.